Good afternoon. I'm Adrianne Linton. I'm a faculty member at the School of Nursing here at the UT Health Science Center. And I haven't had a chance to meet even those of you in the room, so hello to you. And for those of you at the distant sites, thanks for joining us today. I understand El Paso is definitely up and running. And I used to teach there, so hello to El Paso. And I currently teach in Del Rio about half the time, so if Del Rio's on the line, how are you guys doing? And from Lubbock, when I lived in Hobbs, we used to go to Lubbock for excitement. So I know where the good places are to eat and shop in Lubbock. And then Corpus, I need to get down and see you all because I've actually never been to Corpus. Edinburgh, I am familiar with the Valley from when we took our nursing program to that area. So I feel like I'm speaking to people that I know a little bit, at least as we get started today. The area that I was asked to address relates to dealing with what we think of as behavior problems associated with dementia. And because the work that I've done in that has largely focused on a particular strategy to deal with problem behaviors, I'll handle this afternoon's session by sharing that study with you and illustrate some of the ways that this particular approach might be employed in working with patients who do have Alzheimer's or other types of dementia. I've tried to make an adjustment in my thinking here and stop saying behavior problems and think of them more as symptoms of a disease, because I think there's a real mental set there to helping other caregivers as well as family members to appreciate that the things we think of as problem behaviors truly are symptoms of the disease, and that if we can look at managing them as we do any other symptoms, making them as tolerable as possible, trying to figure out what's causing them, then we may be able to reduce their frequency or perhaps reduce the way that we think about them and become more accepting of behaviors at certain times. So if I've got my slides on, let me get going here. I have to get used to this setup. I'm going to back up. And I would like to start by acknowledging my colleagues who were on this study. This was a 3-year study that was funded by the National Institutes on Aging and the National Institute for Nursing Research. And my colleagues are Dr. Marianne Madison, who has recently retired and has left me to carry on the banner alone with our particular area of emphasis. Dr. Brenda Cleary, who was formerly at Permian Basin out in West Texas and is now in North Carolina. And Dr. Michael Lichtenstein, who is here at the Health Science Center and is one of, from the nursing perspective, one of our favorite physicians to work with in relation to dealing with patients who have dementia problems. I'll just first give you a little bit of background related to the area that we studied. As you probably heard quoted before, there are thought to be about 4 million Americans with Alzheimer's disease. This has been my area of emphasis for 10 or 12 years, and it surprises me that the stats haven't changed at all. I keep hearing the same numbers, and yet we keep hearing predictions that the total numbers of patients with Alzheimer's and other kinds of dementias will continue to grow. But nevertheless, even at 4 million, we find that they pose very special needs to the healthcare system and to the healthcare provider to continue to try to meet the challenges of providing the best care we can for these patients and their families. As you probably know, this disease often extends over as long as 20 years. When I first started studying it, I was hearing 5 years was about the life expectancy. And we now know, one, that it probably begins much earlier than we used to think, and we just weren't picking it up, but also that these patients many times survive for a very long period. As Alzheimer's disease progresses, there are a variety of behavioral symptoms that typically emerge. And we find that these can pose a danger to the patient or to others. They can create an unmanageable stress for caregivers. And in fact, when we look at when families do make decisions that nursing home placement is necessary, it's often because of some of these behavioral symptoms that have become unmanageable to that family. And last, they do pose a challenge for healthcare providers. So when the family turns to us, not only during the phase when they're caring for the person at home, but then once institutional care is needed, then we're the ones who have to seek the solutions and try on an everyday basis to make life as high quality as possible for these patients. In addition to losing their activities of daily living skills, the behaviors that tend to develop may include wandering, aggressive behavior, yelling, sleep disturbances, catastrophic reactions, all of which those of you who've worked with this population are probably familiar. And although we've learned to deal with many of these problems, most often through trial and error, see what works, and then if a particular strategy works, do it again. What we would find was that what worked with one patient might not work with another, and what worked last year isn't working this year. And so what we wanted to do was look for a theoretical basis to try to help us understand the nature of these problems, and then build on that theoretical understanding to design interventions that would help to work with the behavioral symptoms. The approach that we eventually designed was based on really two of our observations from working with these patients and their families over many years. One was that the Alzheimer's patient often seems to become more childlike as they progress in the course of their illness. And I've found that sometimes that term is even a little bit offensive to some caregivers, because there's a perception that we try so hard not to treat our older patients as children or to treat them in a childish manner. But what I'm talking about are the kinds of behaviors we see as people become very much affected by Alzheimer's that resemble behaviors we see in children. For example, following the caregiver to the bathroom door, standing outside the door and knocking on it or calling out for them to come. These kinds of things that we typically see in certain stages of childhood. So we were looking at that and many other what we think of as childlike behaviors. We also observed that there seemed to be a rather predictable course of events, so that certain problematic symptoms tended to emerge throughout various stages of the illness. Based on our study, we proposed that these negative behaviors resulted from either the client's misinterpretations of cues in their environment, mistaking things in terms of their purpose, their use, their intention, etc., or also that it might be stemming from caregivers' expectations that exceeded the patient's cognitive abilities. Much as if you expected a 2-year-old to sit at the table and use utensils in an orderly way and not make a mess while they were eating. It's simply not a realistic kind of expectation because of what their capabilities are at that point. So using that kind of principle, we thought if we could find some ways to better understand how the Alzheimer's patient is problem solving or thinking, and then adapt our strategies to the abilities that existed at that particular point. So we looked at the childhood development literature as well as learning theory. And the one we found that really spoke to us when we thought about our patients was Piaget's theories of cognitive development. We came across the work of Barry Reesberg, who is a physician at New York Medical Center, who's looked very much at these stages within Alzheimer's disease, and he's very much, has very greatly detailed and broken them down into stages and sub-stages. And the work that he did has been based on Piaget, and he identified how the cognitive changes through the process of Alzheimer's disease was similar to that of children, except they were going the opposite direction, where your child's skills grew or built upon each stage of development. In the Alzheimer's patients, we seem to see a sequential decline in much the same pattern. And in fact, there's even some evidence that these losses occur in approximately the same period of time over which they were acquired. So I'd like to show you how we put this together. And if I could direct your attention first to the left-hand side of your screen. And I want to go through with you the Piaget levels. We all probably had this somewhere in our psychology or child development, but just for a quick refresher. What we observe in the sensory motor stage, which is from birth to 24 months, we've broken into 2 periods because we really found among our most severely affected Alzheimer's patients, there were those who were at the very extreme lowest level and those who were a little bit above. So we divide them into sensory motor 2 and 1. But in your early infancy period, what we find is that the infant operates on the basis of your neonatal birth reflexes, which fade as they begin to develop other strategies for coping with the world. And that they also begin to develop habits even in very early infancy. And certainly anyone who has children or has worked with children is aware of how soon very small babies do tend to develop habits and to set something of a schedule for themselves in terms of the way that their lives begin to develop. The sensory motor 1 phase we defined as late infancy, and this was where the infant begins with what we think of as rudimentary trial and error learning. Everything goes in the mouth. It might be food. You won't know unless you taste it, and tasting is a perfectly good way to learn about something. So you get this sort of trial and error learning that occurs at this stage. They begin to imitate, so that when they do what they see other people doing. And they also begin to understand the concept of object permanence, where the mother can be away and the child recognizes that the mother still exists, she's just temporarily out of their line of vision. As the child grows from about ages 2 to 7, we have what's called the pre-operational phase of cognitive development. And during this time, the child develops symbolic thought. They're able to appreciate symbols and to think about things that aren't necessarily concrete and right in front of them. They like to be around other people, but they prefer parallel play. So that if you see a group of 2 or 3-year-olds in a room together, they all may be engaged, but more side by side than actually playing with interactive types of games. They concentrate on one thing at a time, often for long periods of time, as long as it holds their interest. And they need very specific instructions. So these children can be civilized if we are giving them appropriate kinds of guidance and instruction and not overwhelming them with what they are to do. So we find when we deal with kids in this age group, things are very much laid out 1, 2, 3, and this is what they can relate to and do well with. The next stage, which extends from ages about 7 to 12 in a normally developing person, is your concrete operation stage. And this is where the true ability to reason begins to develop in the child. They understand rules, and in fact rules are very important to the school-age child. They're unable to comprehend the future, not in a completely literal sense, but in terms of truly being able to anticipate the consequences of their actions and the decisions that they make at that point because of their lack of maturity in being able to deal with those concepts. And then the last stage, according to Piaget, is formal operations extending from adolescence through adulthood. The critics for Piaget have found that there are many normally functioning, healthy adults who are not able to demonstrate what he described as formal operational thinking. So whether that piece is really something essential to our health, well-being, and jobs, apparently that doesn't seem to be true. Nevertheless, the highest level of cognition that he defined was the formal operation stage. And if you would look with me now back on that same slide, okay, you have it, and go backwards. If we start down at the bottom of the right-hand column, what Riesberg defines as the very earliest stage for the Alzheimer's patients is what he calls normal forgetfulness, where there is no impairment that's detectable with our usual means of evaluation, but the patient senses that they're not remembering things quite as well as they used to. Some very interesting work that's going on now relates to our understanding of mild cognitive impairment, or MCI, and this is being defined as this basically a memory problem without any other symptoms of dementia. And I'm wondering, as we learn more about that, if this may appear to be sort of this center stage here between our normal forgetfulness and moving into the early dementia, because the progression of MCI to dementia within a 3-year period is really quite high. So if you have the individual who's basically normal, and most of us have spent at least half a morning looking for our keys or whatever, and that's always a little bit alarming when you work with dementia patients. However, we recognize that that's pretty much a finding in most people. If Alzheimer's is present and the patient develops mild Alzheimer's, then what we see is that they have a decreased ability to perform in demanding employment and social situations. So they may do very well doing the same job they've always done, if it's a homemaker, cooking, cleaning, doing all those kinds of routines that have long been a pattern of life. And it may only be when the person is put into a situation of high stress or an unfamiliar situation that you may find surprisingly they're not dealing with it as well as they normally would have done in the past. And as that progresses, again, going sort of backward here on our slide, if we can bring that back, when you're dealing with the, catch up with myself, the early to moderate dementia, then what we find is that the individual is able to recall their own name, names of family members, but they're not able to remember their phone number. It's one of the first things that is forgotten. They have difficulty choosing proper clothing. If any of you saw the very moving slide presentation that was done some years back called Gramps, it was a photo documentary of a man with Alzheimer's disease. And as his disease progressed, the family has a picture of Gramps engaging in some rather mundane activity wearing grandmother's housecoat. And it seems that at a certain point, Gramps took a liking to this housecoat and wore it most of the time during a long phase of his illness. You'll also see people with things mismatched, shirts on backward, kind of the same sorts of things that you see when you first start letting your kids begin to dress themselves. But that they can physically dress, but they don't seem to make decisions that make sense about what they choose. We also see there's often will require coaxing to bathe, and many times this is one of the things that just makes families crazy. They can deal with the clothes by simply providing only clothes that they think are appropriate or whatever at a given time and keeping the rest put away. But the problem with bathing can become a real issue. And families become very sensitive if they feel like this, the patient is not getting good hygienic kind of care. So this can become a real source of stress. Also at this stage, they can still understand common signs and symbols. When I talk to you about some of the interventions we used, I'll share how we employed some of those common things based on the hope that they would indeed continue to understand those even though verbal directions had not been effective. Again, as the disease progresses, and the slide shows where you're dealing with middle to moderately severe dementia, and in fact, I think I need to go back one now. Yes. With the middle to moderately severe, we find the person still can recall their own name, but they do have recent memory loss. Personal hygiene is just not done unless it's very much guided or directed by someone else. They will demonstrate a very real fear of bathing, particularly if you're dealing with a tub kind of situation. And I've seen especially fearful reactions to the types of tubs that have the hydraulic lift that lifts the person up in the air, turns them around, and lowers them into the water. When I try to think what it might be about this experience that's so terrifying, realizing that if the person does not comprehend what's going on and suddenly find themselves with water up to their knees and then up to their waist and up to their chest, how frightened they must be in not knowing if that water's just going to keep coming up and if they're going to keep going down. So it's helpful to begin to try to think what perception may be like for them. In addition to that, this is the stage where agitation and wandering becomes problematic. The patient is physically able to walk, to unlock things, to get around, yet lacks the judgment to safely do so in an unsupervised environment. I had a family member tell me about her husband who took the garbage out and had done this for years, and even during the time that he was ill would take the garbage out to the street and come back to the home. This one particular day he didn't return. She went looking for him and found him some 2 or 3 miles away still hauling the garbage can. So that the act he knew how to do, but the whole context of it, of why he was doing it, where he was going, simply got lost somewhere in the process. And he lost his purpose in that particular instance. And then as we move into the last stage, where you have late dementia, of course we see a loss of speech. And this is a process that occurs over time. So initially you have paucity of speech, where they use fewer and fewer words. And very often toward the end that will come down to only 1 or 2 words. It may be a word like no, and that's not a real uncommon one that we hear not only in our advanced Alzheimer's patients, but also in small children. Sometimes it's a person's name, sometimes it's a meaningless phrase, something like okay, just almost a rote kind of response that they use for everything. And of course there is a loss of continence, and the patient does lose the ability to eat. So the reason I share all this with you is to just hopefully help you understand a little bit how we took the understanding of cognition from Piaget and tried to relate it to our Alzheimer's patients. Go forward one more. Okay, so the study that we did, the purpose of that was to test the efficacy of using a cognitive developmental model, that's what we call the model that we designed, for behavioral and environmental interventions for persons with Alzheimer's disease. There were 2 hypotheses. One, that there would be a significant correlation over time between Piaget levels and Alzheimer's disease stages. And second, that the subjects in our treatment group would have significantly fewer problem behaviors and take fewer psychotropic medications than subjects in the control group. We had a treatment and a control group. In our treatment group, we had a total of 43 who actually completed the study, and in the control group, there were a much smaller number of 14. Some of the general information about the groups is shown there. The only thing that was significant in terms of the characteristics of the groups is that our treatment group had a higher proportion of whites and a higher proportion of males. So I'll see if you can guess what site we had with a mean age of 76.2, where 40 of them were males. If you've worked in a VA, you would probably know that that's about the only place that you're going to see male elderly subjects outnumbering female elderly subjects, and indeed that was our site. Some of the other information is provided there just for your general information. Also, within our 2 groups, we did testing to measure or attempt to classify each of the individuals in terms of their cognitive level according to Piaget. I'll tell you a little more about the testing in a minute, but you can see there that we have formal, concrete, preoperational, and sensory motor individuals. So we had people who were classified at each of the levels. Only one was able to do the formal skills, and probably this person did not have Alzheimer's disease. But as you know, that's a little bit of a best guess sometimes. And so we don't pretend to be able to be sure that all of the patients that we dealt with did indeed have Alzheimer's and not some other type of dementia. In addition to that, we looked at the baseline medications, and this was very important because we hoped not only to decrease the behavioral symptoms that posed a danger or posed a problem, but at the same time to be able to decrease the medications that our patients were taking. As you know, many of these drugs are completely capable of causing confusion, somnolence, falls, many kinds of negative outcomes that make them less than desirable for patients in this category. However, when you're dealing with patient behaviors that are potentially dangerous or harmful, prevent care being provided, sometimes that's an option that is reasonable. However, the areas that we particularly measured and assessed in our study related to the use of anxiolytics, neuroleptics, and antidepressants. Our treatment setting was a VA hospital that had an SCU, or special care unit, and our control facility was a private Medicaid nursing home that also had an SCU. You may be familiar with the MEAP, M-E-A-P. This is a tool that stands for the Multiphasic Environmental Assessment Procedure. It's an extremely detailed assessment of facilities that enabled us to determine if there were significant differences between our sites that might affect our study outcomes. So it looked at the physical layout, staffing patterns, patient patterns, what else was I going to tell you on that one? Policies, programs, social environment, observations actually made by an individual who spends about a week on site. So there was an extensive assessment of that done in order to assure that we didn't have our results altered by differences in the environments. The Veterans Administration that we used was in Kerrville, Texas. I don't know if we have anyone associated with that facility who's in our audience today, but we found that this has long been one of the most inviting facilities in relation to research for nursing and medicine, with a staff who is forward-thinking, willing to try things, and very open to working with their colleagues from the educational environment. Now, this Alzheimer's unit was designed sort of back when and has recently been totally remodeled, but at the time we did our study, it was what you see a lot nowadays. Somebody puts up a glass wall at the end of one hall and it becomes the Alzheimer's or the special care unit. What's different about it typically is the degree of control in terms of patients being able to come and go. And this was the environment that we had initially. Very much looked like a hospital wing, more than the kinds of environments that we're beginning to move toward for the Alzheimer's patient. In terms of our instruments, there were a set of 6 that we used. We used the Blessed Dementia Scale as a screening tool, so it was administered, and if the patient scored over 20, then we did require family consent in order for them to participate. Even if the family consented, we always sought consent on the part of the patient anyway. So regardless of their mental ability or the family's agreement, if the patient resisted or declined to be included, then that certainly was respected. We used the Folstein Mini Mental State Exam as well, which is another simple to administer kind of tool. And my colleagues were kind enough to name our Piaget test the Linton Piaget, and I don't know how Dr. Piaget might feel about that. But what we did was draw from the original materials that were used or designed by Piaget to evaluate the presence of particular cognitive abilities and put those into a battery of tests that consisted of 14 tasks that were presented to the patient and gave us an idea about how they problem solved. This turned out to be an extremely interesting process because of the similarities we found with what you would find in children in the preoperational stage and in the concrete stages particularly. So it was a fascinating thing to observe with these patients. We also use the Nursing Home Behavior Problem Scale, which is a list, and I'll show you what that includes in just a minute. So it gave us both a baseline and a means of measuring at later points whether we had been successful in making a difference with the behavioral symptoms. And in addition, the meds from the charts were at baseline recorded for the last 30 days so that we had good knowledge about what medicines the patient was taking, their dosages, etc. Here are those points that I mentioned in the behavior problem scale. Includes uncooperative, aggressive behavior, irrational and restless behavior, sleep problems, annoying problems, inappropriate and dangerous behavior. And off the top of my head, I won't try to recite those, but I can make that tool available to you if anyone's interested in it. This is Edie Jessup, who is a gerontologic nurse practitioner at the VA. And the test that she's administering here, if you think back, if you dealt with any of these concepts, is where you present the client or patient with a set of In this case, they were sort of like a cardboard material that are in circles, triangles, different shapes, different colors, and ask them to classify. And so that's what it is that she's doing in that slide. I might say, too, in relation to Edie's role in this, it probably was a real strength having someone that the residents knew and had some trust in. I think she probably was able to elicit their best performance in this process, whereas a stranger would have had, I think would have had to take the time to establish some rapport before being able to get the degree of cooperation that she did. In terms of our procedure, as I said, we used the BDS to determine whether the patient could give consent or if family needed to be asked. We did our Piaget and our mini mental state testing, which is the Folstein, at baseline, then 1 year later, and then another year later. So the actual study took place over a 2-year period. Staff training was a critical piece of this. Obviously, it was not something we could be there and do ourselves the whole time, so it was critical that everyone who was engaged with the patients or residents had the opportunity to understand what we were doing and to help with its implementation. And then, let's see, drug withdrawal, the staff training was initiated, and we also had a very specific drug withdrawal protocol, and that was managed by Dr. Lichtenstein, who worked with the physician's assistant, who's the primary person managing the meds on a daily basis in this particular setting. And then, of course, worked with the physicians in the facility to communicate the protocol, how it would be working, how it would be monitored, etc., and to be sure that they were aware of everything that was being done. Staff training consisted of a series of videos that we made that were instructional, and the non-professional staff only had to see 3. They were the more basic ones on how you deal with people, and the professional staff viewed all 6 of the tapes. And these had to be done as new people came in so that no one worked on this unit, including housekeeping, who had not been through training in terms of this approach. We did design PIN certificates for completion of the training, and it sort of got formalized, actually. We had very spontaneous but enthusiastic ceremonies in which PINs were presented, and the professional staff, I think, wasn't a big deal to them to receive something like that. But for the people at the level of the housekeeping, the nurse's assistant, it's rare that they are included in a lot of these sorts of things. So they were really quite pleased to be given the pins, and they wore them on their uniforms, and it said research associate or assistant or something like that on it, and did acknowledge that their role was critical in order for us to test our approach. And this was one of the times that Mary Ann Madison and I were in Kerrville, and we keep this picture because we were both thin then, and we like this one a lot. Again, housekeeping, anybody. If you were in contact with the residents on that unit, you had to go through the training. And I will say that the VA has probably an advantage of having more stability in staffing than you see in many long-term care facilities, and that certainly was a plus for us. Again, this was just one of the nursing assistants proudly wearing her pin. In terms of the treatment, what did we do? We used a set of behavioral interventions. We also used environmental interventions because we wanted to look at how the environment could support the best functioning possible, but also discourage dangerous, problematic kinds of symptoms from occurring as well. But then in addition to that, as we implemented this approach, we did begin to implement the drug withdrawal protocol. It's really quite a booklet to go through all of the things that we did, but I'll just show you one as an example to give you a sense of how this was designed. When the patients were tested using the Piaget testing, they were classified according to those cognitive levels. So if Mr. Jones had been classified as pre-operational, he would have, they'd put a yellow marker on their armbands, And again, probably an advantage for the VA. People actually have armbands there. But, and then based on that, the nursing care plan was specifically indicating what kinds of assistance they might need with meals. And so that if you're dealing with a pre-operational patient in terms of eating, the things that the interventions you would be using are spelled out there. If the individual was sensory motor 1 or sensory motor 2, then those specific recommendations were also available. These were made available for all of the activities of daily living, eating, bathing, dressing, etc., as well as problem behaviors. So if there were problems with resisting care, that was one of the big ones, wandering, agitation, restlessness, then again, based on their cognitive level, there were specific interventions that were prescribed. And so these were the things that we spent all that training time on in working with people for how do you go about implementing this. What's different about mealtime with a person at one cognitive level and from a person at another level. And again, we have detailed care plans for all of these areas. Okay, in terms of environmental interventions, you've probably encountered people using stop signs, and this is an example of a symbol that often people just react to. It's such a universal sign that whether you drive or not, people tend to recognize that a stop sign means don't go beyond here. And so those have been used with some success at exit doors that you wanted to control, etc. Another facility that I'm aware of all things, had an elevator that went up to an open unit. And it required almost constant vigilance to keep our Alzheimer's patients from jumping on the elevator. And somebody got the idea of putting a do not disturb sign, out of order sign on the elevator. And for the most part, that took care of it, this recognition that it wasn't working. The other things that they've done successfully is put something over, disguise the buttons. So even if you taped like a box with 3 sides over it, and staff could know to reach up under and touch the button, but many times they don't figure out those things. And if it's not something that's visible, very apparent, then they're not drawn to it. Whereas there's just something magical about seeing that door there with that button. You've just got to go up and push it. And so those were kinds of environmental things that people have tried. We did look at colors, pictures, tried to warm the environment up a little bit. It was pretty sterile. And to what extent that might help with behavioral symptoms, we didn't know. But it certainly occurred to us that boredom was probably a factor for a lot of these old soldiers on a daily basis. So we did try to look at a more pleasant environment, using soft and quiet music at times that we hoped would be bedtime, more active music during the day. Thinking about noise level, trying to help people be aware of their voice levels, the meal trays, the cleaning equipment, all those kinds of things, and to think how that might be disturbing, coming in as simple stimuli that the patient can't interpret anymore, realizing that this may be a source of some agitation or unpleasantness for them. And then we looked at trying to design some activities, things that patients could do. There was a courtyard with a large walking area. There's a gazebo that you can't see in this picture. The solid walls are a bit confining, I think. There is a wrought iron gate at the end, and you see there is a resident peering out there. If you can believe this, that's, I don't know, I would guess that patient's not 6 feet tall, so that's probably a 5-foot fence or so. And they had a few who could scale it. So this being an old military population, you know what they did? They put off-limits signs all around the inside margin of the walls. And they didn't have any more scaling the walls after that point. Again, using those familiar symbols, sort of ingrained knowledge about the appropriateness of various kinds of behaviors. This is a walker that can be used with a wheelchair. One of the things that we thought might work was rocking, especially with those who are very seriously demented. The kind of patient who doesn't get out of bed or maybe is just lifted out, who cries and calls out a lot. We thought that the same comforting kind of behaviors that worked with an infant might work with these patients. The rocking chairs were a problem because they weren't designed to give the proper support, so they really weren't safe. But for the patient who could be gotten into a wheelchair, these rockers, you simply roll the wheelchair on it. There are Velcro straps that hold it for security, so your patient can be in their familiar chair and as safe as possible, but still be able to have that experience of rocking.
Did it help? I mean,
The ones who liked it. And you do experiment some. You see what works for one and try it on different ones, but the rocking was popular. And we've recommended with nursing homes where we've done consultation that they put rocking chairs. And often they're real popular items, almost always in use. You can't see the detail on this. My AV person would fuss at me. But what it is a busy box for grown-up people. It's a faucet. It's one of those latch chains that you put on your door where you have to fit it into the little slot. I forget. There are about 6 or 8 things on there. And it's, in terms of people think we're not babying the resident, there wasn't anything offensive to families about having that. And it was something to fiddle with. And so some of the residents would stand there and just turn the knobs and do things on and off, just seeming to be content to be engaged in some activity. Now, one other thing that we used that was very successful with certain residents was the Spinoza bear. If you're familiar with that, it's a stuffed bear, sort of a big one that an adult could hug, and it has inside of it a tape recorder. So people used various strategies, from adding a family member talking to the patient in a calming manner, or favorite music, story, like you could do the books that are available on tape or something like that. But these were seen to be most effective for the most severely impaired, who had lost the ability to communicate verbally, who needed to be calmed. And we observed that very often women would have a doll baby to hold on to, and that was often very effective in providing some comfort. It also is real effective when you're dealing with resisting care. So if you have someone who grabs your arm when you're trying to help them up, a strategy rather than waiting for them to do that is to give them something to hold. You know, if you'll hold the bear for me, I'll do this. Or just hold the bear, a very simple instruction with moving toward them. The odds are they're going to take it. And then you've got their hands occupied, so you can go ahead and do the other things you need without agitating the person so much or getting into a struggle with them. Some of the other facilities, as you probably are aware of, are including lots of home-like changes. We weren't able to do that in this environment because we didn't have the money. But many places are adopting aspects of the Eden alternative with birds and fish and terrariums and all kinds of things that bring the world to the patient, even if the patient can no longer be engaged in the world as much as they might like to. Let's see what else I had on there. Oh, this was just the gazebo, which that's a nicer view of that courtyard. Otherwise, it kind of looked like a prison workout area, I think. In terms of, so what, after we did all this for 2 years, we looked back at our hypotheses to see if we had accomplished what we hoped. And in terms of our first hypothesis, we did conclude that the Piaget and the Folstein scores, and the Folstein is a measure of mental function, did correlate each time. And that's what's reflected on the graph that's on the screen now. If you look at it, you'll see the Folstein measures at baseline and then after 1 year and after the second year. You will see the number of subjects in each of the categories according to Piaget. And we found that the correlations were extremely high over the course of 2 years and were significant at the level of 0.0005. Both scores did decline in the expected direction, so that we knew there would be something wrong with our theory here if the Piaget scores bounced all over the screen and didn't go down in a consistent manner, but in fact they did. Now, of course, we had a few clients who did have some unexpected scores, did better after a year than they had done initially. And I think a lot of things could explain that in terms of how they might have been feeling on that first day, perhaps the medications they were on, various kinds of things. And maybe they didn't have Alzheimer's, but something else was happening. Our second hypothesis was that we would be able to decrease the problem behaviors and also to decrease the drug therapy that was being used for those behaviors. In this scale, you see the scores on their nursing home behavior problem scale, and the treatment group, those that we presented our theory and worked with, are pictured in blue and the control group in purple. You can see that there was an initial difference in the two, but taking that into account over time, there was a significant decline in the behavior problems over the course of the 2 years of our study. And in fact, in the control facility where these interventions were not done, they did improve for a while, and often you'll see that when you have a study. Staff know that things are being observed and that somebody's noting things, etc. And so many times there's sort of a higher level of attention at first to what's going on, although we did try to shield them from being exposed to the details of our intervention. At the completion of the study, the control site problem behaviors were essentially the same place they were at baseline. In terms of the anxiolytic drugs that were employed in this population, again, our treatment group was blue. And if you look at the change over time, within the first year, there was a very significant decrease in the amount of anxiolytics that were used among our resident population. Went up a little bit at the final evaluation. And we did find that some of the subjects didn't tolerate being off of these medications. So despite our best efforts in decreasing the dosages, etc., some patients continued to have a need for that. And we certainly are comfortable with that the patient should not have to suffer when a medication will help them. But by and large, we feel like because of the many adverse effects of the drugs, if their symptoms can be managed other ways, that would be preferable. Also, in terms of neuroleptics, what we were seeing a lot of was Haldol, some Vistaril, and certainly now has been when this was initiated about 6 years ago. And so there are a lot of the newer drugs that are in use now that are not quite as prone to adverse effects as the older ones, but nevertheless they all can pose some problems for the older person. So you'll see the neuroleptic use at the beginning of the study and the extent to which we were able to decrease that by the end of the study. So we were very pleased that not only did the behavior problems get better, show improvement by lessening, but that occurred even with the reduction of the medications. I don't have a slide for the antidepressants, and that was the one category that we were not decreased successfully. And I need to look back at that and see, as I recall, it was fairly low amounts of that were being used anyway, but nevertheless, that was retained. So I would just, in summary on this, like to share a few thoughts with you. And that was that one of the concerns that was voiced when we first presented this idea was that we were infantilizing our patients. And that very much went against our grain. That was not what we wanted to do. What we wanted to do was to create an environment that enabled them to function to their maximum capacity. And part of that environment is to create a situation where they are not expected to do more than they're capable of. And when you do that, then people can feel some sense of self again, some sense of control, some sense of being alive despite the fact that they have this terrible disease. We found that staff did not patronize the residents, and that in fact they worked very hard to try the interventions. and to interact in an adult manner with the residents. We're continuing to study how this approach might be applied in a variety of ways. Because we weren't able to decrease a couple problems. One was sleep problems, which is terrible for families, and no doubt contributes to some of the confusion and agitation of the resident as well, because they're not getting normal kinds of sleep patterns. And the other was annoying behaviors, just sort of whining kinds of things, not being able to figure out what they need and what they want. And we have questioned whether pain might be a factor here because of the age of these people, the number of other medical diagnoses that they have that might cause them to have pain. We've tried to look at whether treating for discomfort might also reduce some of the problem behaviors. And what we've gotten into is extreme difficulty in measuring pain in the nonverbal cognitively impaired person. There are a few tools out there, but with the ones we've tested, we've really not found satisfactory. So that's been a bit of a brick wall for us at this point. We also want to look at specifically ADLs using the cognitive development approach and see if we're able to maintain the ability to do ADLs for a longer period of time, rather than trying to restore them, to at least enable the patient to continue to do for themselves more. And then last, the last proposal we sent in that was not funded, it was shocking because it was the best proposal I've ever written, was to create a Montessori-style daycare, adult daycare center for Alzheimer's patients. Again, drawing on the concept of suiting the environment to the patient rather than expecting the patient to fit to the environment, with designing stations and activities that were appropriate for each of the cognitive levels. And it was just a beautiful study. It was incredible that it wasn't among those selected for funding, but we'll just have to try again. I understand that Dr. Cameron Camp came up with a similar idea that was funded by someone else, and that there are some publications on that look very positive. So we're pleased to see that at least someone with a similar idea is finding that it is most helpful in these situations. Do you have any questions about our study?
I have a question. It's not so much about your study, but you're saying that you didn't have a lot of success in decreasing the annoying behaviors, the repetition of help me, help me, help me,
Some of those kinds of
going
things.
into some, those types of things. What were some of the things that you tried?
It was not so much, you're asking me about those exact behaviors. Let me get that for you. Okay. I do have the care plan that completely spells it all out, and off the top of my head I sort of get them blended together, but we do have them spelled out for the specific behaviors, and I'd be glad to share that with you.
I'd like to see that.
Okay.
Did you try any of the, like you were comparing with PHAs, that any of the toys as, the age-related?
Age-appropriate toys. We didn't too much. We were trying so hard. Do I need to repeat the question for anyone? If so, what she asked was if we tried any of the age-appropriate toys in terms of stages that would be associated with Piaget. And we were trying so hard to not give the impression that we were presenting a childish kind of approach that we didn't do that. But the materials that have come out of Cameron Camp's work, he has a very nice booklet on activities for dementia patients, and some of it does use toys or it uses modifications of toys. It's sort of drawing on the same concept, but just using something that would be identified as more adult kinds of things. To answer your question, we didn't, but I think it would work.
Where can we find access to this booklet that Cameron Camp?
Just contact me. I'll give you my phone number before you leave, and I'll give you the address where I got it.
Okay.
So. Okay, we weren't too sure how our time would work out, so I had some other materials, but I suspect because it's 15 till, that we'll be wrapping up for the day rather than trying to cover anything else. I think you all have probably had a very long day. Distant sites. In the absence of any objection, we're going to close up here. I don't know if Lily had other directions or information for you, so I would wait around just a few minutes in case. Thank you. Hear me yet? Del Rio?
Yes, I was asking about the handouts from the previous speakers, if they would be sent out to the distance site.
I don't
I
know
got
if...
the ones for...
Okay, it's Del Rio. We'll have to let them know. There's no one here representing them right now, so I do not know if they had handouts available or not, but we'll certainly let the GEC know so that if there is something, it will be sent to you.
Okay, thank you very much.
Oh, wait, here's Lily. Here's Lily. She's the lady. She knows. They said, Lily says yes, and I don't know, do you need to say anything to them before they go, Lily? She says, oh yes, don't go away.
I missed it, but I know I thank you for it nonetheless. Hello, everybody. We need to be sure that all of the registration forms are in. Any new participants need to fill out the registration form and get it back to our campus. Please remember registration forms. And yes, all of the handouts will be mailed to you in your packages. Okay, and I guess that concludes our program for today. And thank you for participating.
What goes up must come down. Spinning wheel got to go round. Talking about your trouble